Anybody else waiting to come in? Okay, so welcome to the last session on this stream, and it is a great pleasure that we got two colleagues from the British Heart, one colleague from the British Heart Foundation and one colleague from an acute trust. So that's really nice. So welcome both. So first up is Chris Annus, who's the Business and Service Development Manager for British Heart Foundation. And Chris is going to be telling us about how the British Heart Foundation has been involved in co-producing across a pathway of care. Is that right, Chris? Have I got that indeed, just about right? And then correct. Following on from that is Dr. Julie Walker, who is a specialist nurse who works in the East Cheshire NHS Trust in cardiology. So she's going to give us some perspectives around innovative models of care for managing long-term conditions around heart and circulatory disease. So really interesting stuff. Over to you.
Okay, thank you all very much indeed for coming to this last session after two quite full and comprehensive days. It's very good. We're very pleased to be here from the British Heart Foundation, and as you're probably aware, the BHF is the biggest independent funder of cardiovascular research in the United Kingdom, and you're probably aware of the resources we provide, our lobbying and policy work. What people are probably less familiar with is the fact that we invest around £27 million a year in our prevention and care programme, and that is actually developing different new innovative models of care to support the greater integration of management of cardiovascular disease in the UK. Now, these are grant-funded projects that are delivered by NHS trusts across the 4 nations, which are independently evaluated and then also evaluated and accredited through the QUIP programme and through NHS Evidence. So they are independent and objectively evaluated as well. The impact evaluation is looking at patient experience and clinical outcomes, obviously. It's looking at the impact on services, especially reduction in inpatient beds, but not just that, and productivity and costs differentially and across the whole health and social care system. Most of our priorities, and this is a very good example of one of them, are trying to address the 3 key priorities in the cardiovascular disease outcomes framework that the BHF contributed to, which are really about there's a lot of rhetoric around integrated care, but how do we manage cardiovascular disease as a single family of diseases? Patients we know often receive care from multiple teams in a disjointed and very inefficient way. And indeed, it's not just the symptoms and management of cardiovascular disease, but it's managing multiple comorbidities really. As we're reaching an aging population, we know people over 60 that suffer from cardiovascular disease quite often have at least one other long-term condition over 65 too. So it's a challenge that we need to try and address in terms of the solutions. So we need a more coordinated approach to assessment, treatment and care. This has a knock-on effect on patient experience and safety. But also how do we, in real life terms, deliver proper care planning, support self-management throughout the whole course of the condition and including end-of-life care as well. So I'm absolutely delighted to introduce Dr. Julie Walker, who is delivering one of 9 integrated care programmes in East Cheshire, who's going to talk a little bit about the establishment of that project and some of the learning. And we'll speak for about 20 minutes and then have a little Q&A session at the end. So over to you, Julie.
Hi everybody, and thanks very much for coming. It's the end, as Chris said, of a long couple of days for you, and I hope you find our little project interesting. It's been obvious that there is a great need for change in the NHS. We can't go on delivering care at the level that we're currently delivering at. There's been a 15.5% increase in emergency admissions for coronary heart disease between 2009 and 2011. And there's a 45% increase in associated inpatient costs nationally. We know that secondary care is not equipped to deal with the increases in demand. And in East Cheshire particularly, we've got the fastest growing elderly population in the northwest. And it's anticipated that healthcare demands for long-term conditions could increase substantially as a result. The current economic climate makes increases in beds neither feasible nor desirable. And long-term condition strategy requires that care is delivered closer to home. But we know that as an organisation and as a primary care organisations, that GPs and other primary care practitioners are often ill-equipped to manage specialist conditions in the community. in Macclesfield, we had a rapid improvement event in November 2011 to discuss what was wanted by the local area for a cardiology service. GPs said that they wanted a point of contact for clinical discussion, so they didn't have to always send patients into hospital. They wanted comprehensive discharge planning, upskilling of primary care staff to manage more patients and services that were more responsive to patients' needs. And the commissioners said that they wanted to reduce admissions, readmissions and length of stay, and also to reduce duplication of care, which we know is a problem. The BHF were asking bids for innovative projects in managing long-term conditions in cardiology, so I thought, well, let's put a cheeky bid in. So after we'd sort of had this project thing, I thought, well, how can we respond to this? And I thought, well, nurses could do this. And we started off by doing an initial pilot project within the hospital, which was a huge success. But there was myself and one other colleague who were actually trying to identify all patients with cardiology conditions that came into the hospital and make sure that they were treated in a timely manner, and that, rather than having to wait to be assessed by one of the cardiologists. We were concentrating on patients that were admitted with chest pain, atrial fibrillation and heart failure, because we know that in cardiology those are the patients that take up the most resources. And we know that when we looked at our length of stay, it was longer than the national average for all of these conditions, and it's probably due to the patients in our hospital not being seen by a specialist early enough. They get usually admitted under a general physician, and then it would take 24 hours or more before they were actually seen by a cardiologist. And GPs and others in primary care, as I'd already said, were not properly equipped with the knowledge and skills to prevent admission or readmission. So we had actually got quite a disparate cardiology nurse team. And our trust actually integrated with the community trust earlier last year. And that meant that we'd got 1.8 whole-time equivalents cardiology specialist nurses working in secondary care. And we work very much like generic nurses in cardiology, managing a range of cardiac conditions, which sort of fitted in with the cardiovascular outcomes framework. But then we'd also got some nurses working as community heart failure nurses that were just concentrating really on managing patients with heart failure in satellite clinics in the community, and they were also doing home visits for those patients. Our bid actually from the BHF funded 2 whole-time equivalent cardiology specialist nurses for two years to enable us to actually amalgamate these teams and develop an integrated cardiology nurse team with a remit to facilitate care for all patients with a cardiology problem requiring specialist input across both primary and secondary care. And we were very fortunate, we had full support from our consultant cardiologists. We've got 2 full-time cardiologists and 1 part-time cardiologist. But the problem is that in an MDGH like ours, the cardiologists aren't actually there all the time because they have to go and do their work, their interventional work at tertiary centres, etc. So the actual presence of the cardiologist in the DGH was actually a lot less than 2 and a bit whole-time equivalents. So the aims of our project were to reduce admissions, readmissions and length of stay, but importantly also to facilitate patient and carer self-management and enable more patients to be managed in primary care, and also to improve end-of-life care. So how are we actually rising to this challenge? Well, developing generic cardiology nurse specialists was important, and making sure that our heart failure nurses could also manage patients with atrial fibrillation and angina particularly, because often these conditions they coexist, and it's difficult to actually separate out heart failure from atrial fibrillation and angina, etc. We wanted to increase the amount of community clinics because we live in a rural area and patients often have to travel quite a long way to the hospital. So we wanted to be able to make our clinics more accessible to patients. And we also wanted to be able to deliver either day case diuretics or IV diuretics in the community. We also needed to develop education for GPs, primary care practitioners and palliative care partners, and also enable patients to support them to develop the skills for self-care. Just to expand upon a couple of things that we do, the Cardiac InReach, we proactively identify patients on the emergency floor who are admitted with cardiac conditions. We currently don't provide a 7-day service, but that's something that we're looking into. But when our nurses are on duty, they actively go through A&E, through the emergency admissions unit, through the medical assessment unit, to identify patients that are admitted with cardiac conditions. We then sort of initiate the agreed pathways for these conditions so that patients' treatment is not delayed because the specialist expertise is not there. We ensure that each of the patients that we assess have appropriate discharge advice and information, and if the patients can't take it, then we give it to the carers and ensure that they know, what the plan of care is following discharge. We increased the community clinics. We needed to utilise and expand upon existing community heart failure clinics so that we could manage all cardiology follow-up patients. For instance, if somebody comes into hospital with atrial fibrillation, they're often discharged with suboptimal heart rate control, and that can result in them then being readmitted to hospital within a very short period of time because they may develop things like decompensated heart failure. So our nurses they would traditionally get an outpatient appointment 6 to 8 weeks post-discharge, but our nurses will follow up all of these patients within 2 weeks of discharge. And this provides, because we'd already got the heart failure clinics, we've managed to expand them, and that gives us extra flexibility in providing clinics that are geographically closer to patients' homes. We also have a telephone helpline with our contact details so that patients can give us a call if they have any concerns about their condition at an early point. And we always give them early pointers as to what might be contributing to a deteriorating clinical condition. One of the things we've been very successful in developing is delivery of community intravenous diuretics. We have actually developed a very successful pathway with the home intravenous therapy team to develop and deliver IV diuretics to suitable patients in their own homes. This pathway sets out roles and responsibilities and parameters for safe management of these patients, and were developed in conjunction with the consultant cardiologists. But also with the Greater Manchester Cardiac Network, we developed quite a robust pathway for delivering this service. The role of the home intravenous therapy team is to assess the home circumstances to make sure that they're suitable. They manage the IV access either through cannulas or midlines or PICC lines. They deliver the infusion, but in order to prevent duplication of care, they also do some of the tasks that would traditionally be done by the heart failure nurse, really. They weigh the patient, they take the blood for urea and electrolytes, monitor their blood pressure and heart rate, and if they have any problems or if the patient falls outside parameters that we've preset, then they would liaise with us by telephone. The cardiology specialist nurse team provide clinical input and weekly assessment of all of these patients who have intravenous diuretics, but we do it more frequently if it's required. We also are non-medical prescribers, so we're able to prescribe the treatment for the patients. And as I say, we liaise with HITS by telephone virtually every day. Unfortunately, the HITS team doesn't always have the resource to be able to deliver IV diuretics in the community. It's only a very small team at the moment, still hasn't been, the funding still hasn't been substantiated, and it's still very experimental, so it's a little bit fragile if somebody goes off sick. But we do have the facility of bringing these patients into our day case unit to actually facilitate IV diuretics if that should become necessary, although we've only had to do that a couple of times since we've been doing it. This is just a quick table of the patients that we treated. We started doing intravenous diuretics in the community in October 2012, so about 7 months we've been at it, really. And we started off very slowly, and we're still, because of the resource issue, we're still taking this quite slowly. It was a pathway that was very difficult to get people to accept, so we wanted to demonstrate that it was quite safe to the skeptics. We know that the patients that benefit from that end up having intravenous diuretics are often the usual suspects. They're the repeat offenders. They're the patients that bounce in and out of hospital. They've usually got advanced heart failure. And you can see that to date, we've actually had 6 patients in total, with a total of 16 episodes of care. the number of bed days, and these figures are only accurate up until 3 weeks ago. We've got a couple of patients that are having IV diuretics at the moment, so these numbers are now greater. But just from October last year, with a very limited service, we've already managed to save 133 bed days, which I think you'll agree is quite a substantial saving. Another part of what we do is about education and ensuring that all health professionals have the knowledge and training needed to support people living with cardiovascular diseases. We've developed a rolling programme in conjunction with the British Heart Foundation of education for community matrons, practice nurses, district nurses and hospice and nursing home staff. We're also in the process of developing an educational programme for GPs, out-of-hours services and managing these conditions more effectively in primary care. We do know that patients are more likely to be admitted through the out-of-hours service than through the general GP service. So, that's a big area that we need to concentrate on. And also being able to give telephone advice to GPs, if they've got particularly challenging patients. So, in conclusion, the aims of our project of developing generic cardiology nurse specialists, it supports the cardiovascular outcomes and long-term conditions strategy by supporting patients to live healthily and independently and making sure that all health professionals have the knowledge and the training needed to support people living with cardiovascular diseases. I'm aware that I've rushed through that rather a lot, but has anybody got any questions? Thank you.
No problem at all. Come and have a seat. Just have a little break there for a moment, and we'll work through. Come and have a seat. So, thank you both for that. So we've really heard a pathway, an integrated care approach through a team, really working across primary and secondary care, with some significant secondary care utilisation benefits there. So can I just kick off with a quick question to sort of ask, how were primary care colleagues involved in the co-production of the pathway that you've been describing?
Well, is that working? Before I actually put the bid into the British Heart Foundation, I did actually have a meeting with the clinical commissioning group to see whether they felt that it was a project that they felt should be supported by them. So they were actually signed up to this before we actually put the bid into the British Heart Foundation. They've been very supportive in enabling us to take this forward and to smooth out the barriers to accepting the pathways, really. They did actually sign up at the time to saying that they would substantiate funding for our nurses once the project was up and running if we could demonstrate that we were effective.
Okay, over to you. Questions from the floor. Colleague over here down at the front there.
Two questions. First of all, what was your biggest surprise about the benefits of the scheme? And secondly, what does the future hold? Have the CCG now committed to taking up the payment and so on? So how does the future look for you?
In answer to your first question, the biggest surprise to me was actually how quickly we managed to facilitate development of the generic cardiology nurses, and the way in which we've managed to rapidly introduce community IV diuretics. We had done a lot of preparatory work. I've been working with the Northwest Cardiovascular Network to develop protocols, community protocols for IV diuretics. So I was already on board with all of that. We'd already got the protocol well developed before we actually started this project, really. But I know that a lot of other areas have had great problems in getting their pathways accepted and getting people to take clinical responsibility. I guess the reason why we managed to be so successful is that most of the cardiology nurse team are actually nurse prescribers. So we actually are able to prescribe medications and and be accountable for the clinical management of these patients. So I guess that was my biggest surprise. And I guess that the best thing that we did was employ really dynamic people. And if we hadn't have employed the people that we did, I don't think that we would have made such great inroads. Now, as far as the CCG is concerned, I'm always very sceptical when CCGs say that they support a project on the basis of they'll support it on the basis of success. We've actually been told that they're going to continue supporting us. Whether that will be the reality when we get to a year in October remains to be seen.
Okay. Any other questions from the from colleagues in the audience there? Are there any clinical commissioners in the audience? Hands up if you're a clinical commissioner. What do you think? Fancy doing this? We'll bring the microphone round to you.
Excellent, really. Can I just ask, any adverse events with the 6?
None at all. We've had one slight complication that we didn't really envisage. And we'd actually developed separate pathways for patients who were being actively managed and patients who were on palliative care. And one of the things that we never really addressed in our operating procedures was the fact that patients that have heart failure actually have a transition into palliative care. So when you get to palliative care, there are certain things that you no longer monitor, for instance, such as renal function. And that has just thrown up a slight little hitch because our protocol doesn't actually allow us to manage that. So we've had to have special dispensation for one of our patients who has now become palliative via the cardiologist who are actually sort of sub-managing this situation. But apart from that, no, we've not really had any adverse events or anything like that.
Okay, colleague from the question here.
Hi, yeah. I just wondered if you'd had any opposition from any secondary care services or consultants to the, because you're moving patients from secondary care back into the community or keeping them there.
Absolutely none. But I think that's got more to do with the fact that our hospital is a very small hospital. We've got a catchment area of about 220,000. I've worked in the hospital for 20 odd years. Everybody knows me. And one of the acute care consultants who obviously a lot of this work originally fell on actually used to work in cardiology with me. So I think an awful lot of history has made this a lot easier to manage. I think that it may well be a lot more difficult where you don't have those prior relationships.
Being very modest, I think it's leadership being demonstrated there. Any other questions from colleagues? There's one right at the back there.
Hi, I was just wondering whether there was any plans or any interest from, say, for instance, Leighton Hospital to duplicate what you've done.
Leighton, you say?
Yeah.
All right. Well, as you know, we're sort of our primary care trust is actually Central and Eastern Cheshire Primary Care Trust, which is the central part is covered by Leighton. So at the moment we're actually just focused in the east. There has been some interest from the commissioners that they would maybe want to expand a similar service over to Leighton. However, the way in which the specialist cardiology nurse services have developed in Leighton is very different to what they developed in East Cheshire. I believe that the only provision they have with cardiology nurse specialists in Leighton is with heart failure nurses based in secondary care. So they haven't got the same kind of basis to start from that we had. So I think to get to where we are at the moment, I think will be a bigger journey for Leighton and the central side. Okay, we're nearly there. Anything else anybody wants to ask? I've just got a very quick closing comment to Chris then. So one of the challenges for us in commissioning is to work in a productive way with our third sector colleagues. So how can the British Heart Foundation help clinical commissioners in facilitating these things?
Well, one of the reasons that I think we're in a strong position as a third sector organisation is that we have a vested interest in evidence-based practice being rolled out at scale, really. So we're investing in these programmes so we can actually show the clinical and cost efficiencies of them. We have, for example, 12 similar projects with home-based RV diuretics that we're currently testing. We've had huge success with that, no adverse outcomes. I think the benefits for clinical commissioners about how we can demonstrate that the cost savings are applicable at scale, really. And I think relatively small programs don't necessarily release enough cost savings for us to then reinvest some of that saved resource into developing community-based services, because we can only decommission, or I'd like to say recommission, community-based services from the acute sector if we relocate that resource. But what we're trying to do is to develop the evidence base and be seen as producers of evidence-based clinical care pathways, and that's why we want to try and work with QIP and NHS evidence to show that this is an independently validated intervention, and begin to link up we've got several quite disparate projects, but each of them I think has synergy with each other. So there's a lot of rhetoric about integrated care. What does integrated care look like? And I think it's going to be a step change, really, where we begin to get, evidence base of the value at scale of how we're, managing patients better, and also looking at, as we said earlier, managing comorbidities, really. One of our next projects is looking at the year of care, the work that's been done around diabetes, transposing that onto cardiovascular patients, because, again, multiple comorbidities, really. So we want to be seen as a commissioning support entity or function to support service redesign where we have the evidence, or where we don't have the evidence, where we can invest in interventions and evaluate them to add to that evidence base.
Okay, I would like to thank Chris and Julie very much for that really enlightening presentation and the demonstration that these things can actually make a difference. So thank you to you both. And I'd like to thank all of you for listening and asking such great questions. Thank you very much indeed. See you next time.